But welcome back if you're returning, and welcome too if this is your first time with us. I just want to preface that, as I mentioned last week, but for those who weren't here last week, this is a new format for us. We are really excited that it's turned out as well as it has. I know it's new for everybody. There's some challenges, but we're all learning a lot together. And I think you need to be proud of yourself for having gotten here, figuring out a lot of this technology to be able to come together, because this is a lot of what scleroderma is about in general, is learning to adapt to challenges and barriers, and finding ways to get around it. Just want to do a few reminders just to help make this conference run smoothly. We ask that everybody mute their microphones and cameras during the presentations. Of course, the microphone helps us not hear background noise. And for the camera, it helps us see the main speaker a little more easily. It allows you to see them more easily. Also may help with your Wi-Fi connection. You may have a more smooth connection during that time. You'll see I have some icons down here under the welcome sign. This is your microphone icon. You'll see that at the bottom of the screen, and if you click on it, you'll get a line through it. That means you're on mute. You'll also see a camera screen, and if you click on that, it'll say on or off. And then we also want to encourage you to use the chat box. If you look for this icon at the bottom of the screen and click on that, you can ask questions in the chat box during the presentations, and we're going to come back, and Melody's actually going to be reviewing those and then bring those questions up at the end of each presentation so we can answer your questions. At the end of our day, though, around 12 o'clock, we will open it up for you to ask questions with your microphone. So if we don't get to all your questions, or something comes up that you just want to ask orally, we'll have time for that. Please be on the lookout for an email from Susan after the conference. We're going to have a link on it to get feedback from you about how things went, what you would like to hear about in the future, anything we can do to make things better. Hopefully we won't have to do a virtual conference alone or exclusively next year, but more than likely we'll have some element of that to increase the ability for people to participate. So if we do a live one, we'll probably still have a Zoom element. We're going to take a break around 11:10, so you have about 10 minutes to do a little stretch break. And this is just a reminder for everybody, and because this is going to be recorded, that this is part 2 of our 2021 conference this year. So be on the lookout. Francis is recording the presentation portions of the conference, not when you speak personally, just to protect your privacy. And you can go back and look at those presentations, or if you know somebody who couldn't attend today or last week, they can see them. Please also visit us at the Scleroderma Foundation website and join us on Facebook if you aren't already part of that. So there's information about how to join our Facebook on the Scleroderma website for South Carolina. This is the national, and then you'll click on our state and get to our chapter website. So this is our agenda for today. I'm going to do some introductions of our team. Last week we did a lot more information, shared more information about the South Carolina chapter and the foundation, but today I want to just make sure you know who our team is, the people that you could be working with, interacting with, or here advocating to help you. Dr. Silver is going to lead us off as the first presenter, and he's going to share some information about patient treatment updates. Dr. Hant will follow, and she's going to speak about COVID vaccine. We'll take a short 10-minute break, and then Dr. Fegahli-Bostwick is going to be our last presenter and talk about her research updates, and we're going to get a tour of the lab, which I'm excited about because I've never been able to do the lab tour, so this will be my first tour. Then at the top of 12 o'clock, we will open it up for questions using your microphones, and then we'll just say goodbyes. Encourage you to join us at future events, and specifically the Thomas Mills Memorial 5K in Columbia, which will be occurring in October. So just want you to meet all of our board members. This is an all volunteer team, and this is important to appreciate, I think, all the hard work everybody's doing to try to make South Carolina a place where people with scleroderma can get information and get resources and feel supported. We consist of a board, and I'm going to open up my screen because we want to do a shout out. So Frances is going to highlight. So when I call out your name, do a wave and put your cameras on. If you are on this list, put your camera on so she can find you. So Susan Melvin is our president. And you probably know Susan. You get communications from her all the time. She knows you too, by the way. She does an excellent job getting to know our scleroderma community in South Carolina. I'm Karen Kemper, and I'm the vice president for our chapter. Melody Breen is our secretary. Melody, yahoo! She also is our support group leader for one of the co-leaders for the Greenville support group. Frances Parrish, say hi. Our treasurer and our media expert, wherever she is. She's not highlighting herself, or I'm not seeing her. And then Bobby, there she is. And then Bobby Francis is another board member, member at large. We have 4 support groups in our state, in Charleston, Columbia, Greenville, and Piedmont. Below this list is our list of support group leaders. If you weren't here last week and didn't have a chance to see the video that they put together that highlighted what they're doing in their support groups, please be sure to go back and look for that video that's in the part 1 presentation. It was excellent, and they just did a fabulous job. Patty Newman, Patty's here. You find her? There she is, Patty. And then Sarah. There are Charleston support group leaders. And then we've got Mallory Hartzell. And I don't know if her mom Susan is here, but Mallory's here. Hey, Mallory. Is Susan here? Great. Yay. Hi, Susan. Now, are Bridget and Susan Widener here? I didn't think I saw their names. Okay. And then, of course, Melody Breen and Kimberly Parker. And I don't know if Kimberly's here this week. And then we have our team from the Piedmont area, Ashley and Ryan Goodner. Hello. And is Lakeisha here again this week? Not this week. So you can meet her and as well as Kimberly at in the video. We also have additional volunteers that we could not do the work we do without their help. We've got Katie Gentry and Loretta and Doug Horton. They're part of Thomas Mills' family, who our 5K race is in memory of. They helped make that happen. They were the spearheaders of getting that memorial event to happen in Columbia. And Michelle Smith. Is Michelle here? And is Katie and Loretta and Doug here this week? They were here last week. So they helped tremendously with the event in Columbia. And then we also have Sarah Smith and Terry Hayes. They help us tremendously with the patient conference, especially when we're in our traditional setting in Charleston. There are boots on the ground there in Charleston. And then, of course, we have our medical advisors. Dr. Silver is our major advisor, and he is really why we even have a conference. He was the originator of the idea, and Susan just said, okay, do it. I remember thinking, I don't know what she's thinking, but they pull it off and they make it happen. So Dr. Silver here, say hello. Can you find him, Francis?
I can, but my spotlight function went away.
Oh, okay. Well, I'm just going to move. So we also have advisors that help us in a lot of other ways. And there's Dr. Silver. Yay. We've got Dr. Deanna Baker Frost. I don't know that I saw her come in yet today. So she works closely, certainly with the research and clinical aspects down at MUSC, but she also works with the support group in Charleston. So she is a key player down there. And then we have also from MUSC, Dr. Carol Fegahli-Bostwick. She's here today. She's one of our presenters. So did you lose your function? I won't.
I did. It's not allowing me to. It's weird.
And then we have our medical advisors from the Midlands area, Dr. Geckeritz and Dr. Kaki Bruce. I don't know if I saw their names here as well. Yeah, there's Dr. Carol. And so they're our advisors in the Midlands area, and we appreciate they support our, there's Dr. Bruce. They support us in the Columbia area and provide a facility when we're meeting face-to-face, as well as they provide a lot of information support too, and our speakers. So this is our team, and we look forward to any of you wanting to become involved in our team in the future, supporting us with the walk or supporting us in the patient conference in the future, or any other efforts that are ways to raise awareness, raise funds, or promote education for scleroderma in our state. Now, that being said, we are going to segue to our first presentation. I think I'm doing okay on time. Woohoo! We are always really grateful to have Dr. Silver share information with us, and he is a faithful contributor and advisor for us. And today, last week he talked about research updates. Today he's going to share with us some treatment updates. Dr. Silver is a distinguished professor in rheumatology and immunology in the College of Medicine at MUSC, and he's the co-director of the Scleroderma Center. And he was the former director, or he is the former director of the Rheumatology and Immunology Division, and Dr. Oates is now that director. And he was here last week, but I don't believe he's here this week. Is that right? Okay, so we appreciate that. So, let me just remind everybody, if you would please remember to mute your microphones. And if you have questions along the way in the presentation, please type them in the chat box, and Melody will be keeping track of them. So Dr. Silver's has from 10:10 to about 10:40, where we're going to leave the last 5 minutes or so for questions from the chat box. So please be sure to put your questions in there along the way so we have them. If by chance you don't get to have your question answered during that time, or something comes up later, we have time at 12 o'clock to open it up for additional questions. So I'm going to unshare the screen, and now Dr. Silver's going to share his presentation screen.
Okay, thank you, Karen. Let's see if I can figure out how to do this.
Yeah, bear with us, you guys. This is all new for us too, so we're learning how to hop back and forth.
Okay.
Yay!
So far, so good, right?
Yeah, we're getting there.
Whoop, wrong one. There we go. Okay, can everybody see that?
Yes.
Okay, good. Well, first of all, I want to once again thank Karen, Susan, Francis, the entire board, all of the support group leaders, and everybody who participates every year, and congratulate them all on last year's award, which is shown here on the left side of the screen. The South Carolina chapter won the National Award for Outstanding Education Program for the second time. So we're obviously using a different format this time, but I hope next year we'll be back to our old venue and our old format. So again, congratulations and thank you everyone for your efforts. So last week we talked about the research being done at MUSC on scleroderma. And I think Karen and Susan asked me to talk about treatment updates and this week. So what I've done, and let me just give you this disclosure. This is a conflict of interest disclosure, just to let you know that I have grant and research support from the NIH and from Boehringer Ingelheim Pharmaceuticals, and work from various other pharmaceutical companies for whom we're doing clinical trials at MUSC. And also I review grants that are submitted to Boehringer Ingelheim and also to Actelion. And my other disclosure is that I'm going to discuss some drugs for scleroderma that are not yet approved by the Food and Drug Administration. So what I would like to do in the next 20 minutes or so is just to update you on treatments for scleroderma, particularly highlighting research that's been published in the last 12 to 18 months relating to the treatment of scleroderma. And so we're going to start with the skin, the major manifestation of systemic sclerosis. And as you can see in this slide, some patients have relatively limited involvement of their skin, whereas on the right, you have patients who have more widespread or diffuse involvement of the skin. And not shown on this slide is another smaller subset of patients, maybe 5 to 10% of patients who don't have any apparent involvement of the skin, but have definite scleroderma affecting internal organs. So, but the skin is the major manifestation, and many of the clinical trials that I'm going to go through have been directed towards trying to find antifibrotic or other medications that will impact the skin. Now, this is a very challenging area to study for physicians and researchers and people in the pharmaceutical industry. So one of the ways you can assess the involvement of the skin is to have a skin biopsy. And many of you have had this either for diagnostic or perhaps research purposes. And as shown on the bottom slide of this slide, which comes from my colleague, Francisco Bowen, who's now at University of California, San Francisco, this is a skin biopsy. And I think Carol Fegahli-Bostwick may show you more of this in her talk. But the dark red portion at the top here is the epidermis, or the outer layer of the skin. And this pink area below it is the dermis. And that's the area that gets thickened in people with scleroderma. And as you can see, it can be mildly thickened, moderately thickened, or severely thickened. And you can see the depth of the dermis is much greater in people with more severe involvement. Now, in the clinic, we can't do biopsies every time we see you. You'll be happy to know that. So we do something called the Rodnan skin score, the modified Rodnan skin score, which is when we pinch you in various parts of the body and to see how pliable the dermis is, or the skin is. And you can see here's a normal example of skin where you can pinch it. In number one is mild thickening. As you go across to the right, moderate thickening, where you can barely pinch it, and then severe, which is so tight that you can't even pinch it between your two fingers. And these correlate with various degrees of thickness of the dermis. So you'll hear us talk about the modified Rodnan skin score, and the maximum score you can attain is 51. And think of it in terms of golf scores. Lower is better. 0 is the best. We use this method to assess progress when we're evaluating patients in our clinic, and certainly when we're assessing whether a potential treatment is effective or not. So a number of studies have been published, either in abstract form or in full publication, manuscript form, in the past 12 to 18 months, looking at different treatments and looking in particular on the effect of those treatments on the skin score. And so this was a study that was published last year, looking at a drug called lanabecin. It's got several different names, but this is the cannabinoid receptor agonist, or this binds to one of the cannabinoid receptors and activates it. And there are at least 2 different cannabinoid receptors, CB1, CB2, and this little cartoon here shows the distribution throughout the body. This particular drug, which was made by a company called Corbus, binds just to the CB2 receptor, which is in the peripheral area. It's not in the brain or the central nervous system. So theoretically, this should have an impact peripherally, but not affect your sensorium or give you the euphoria that is associated with other cannabinoids or with marijuana, for example. So there was a lot of excitement about this drug. It was being studied in a number of different diseases, scleroderma, lupus, I think MS as well. And the excitement sort of came from this study, what was called a phase 2 study, which was a small number of patients for a short period of time. And here we are looking at the skin score. So this is time on the x-axis going from 0 to 16 weeks. So very short duration of study. And on the y-axis, you have the skin score. And you can see the patients who were treated with the placebo, the control group, had a decline in their skin score over time. And the patients who were treated with the study drug, the cannabinoid receptor agonist, also had a decline in their skin score. This is one of the challenges in clinical trials when you're looking at skin score, because the natural history is for the skin score to improve or to go down even without treatment. So you're looking for a difference between the two, and you can see that there is a difference, it would appear, at 16 weeks, but there's a lot of variation. That's what these error bars are about. But there was a lot of excitement. This was a phase 2 trial, and the company then went on to do a much larger, what's called a phase 3 trial. And guess what? It failed. So they could, at the end of this study, they could show no difference in the skin score between the patients who were treated with lanabecin or those who received placebo. So the no difference in terms of the outcome at 52 weeks. So a longer duration of treatment, a larger number of study patients, and this study failed. What happened to the stock of the company when it was announced? When this paper, the outcome of the results were announced, you can see that the stock price tanked and hasn't really recovered since then. So disappointing, but not terribly surprising, given the fact that the phase 2 trial was of short duration and small number of subjects. So back to the drawing boards. So this is another study that was published last year of a drug called Riociguat. This drug has FDA approval for the treatment of people who have pulmonary arterial hypertension, either idiopathic or what we used to call primary pulmonary arterial hypertension, or pulmonary arterial hypertension related to systemic sclerosis or other connective tissue diseases. So this was a large phase 3 trial, double-blind, placebo-controlled, many different centers around the world. And again, this is the outcome at 52 weeks. So you see here in blue, the patients who received placebo, their skin score didn't really change over the year. And here in yellow, the patients who received the study drug, Riociguat, their skin score decreased or improved. But again, there's a large overlap between these two groups of patients. So this study did not meet its primary endpoint, which was the change in skin score over time. So there was some suggestion that patients who received the Riociguat in the orange here were less likely to progress compared to the patients who received the placebo. But this was not the primary endpoint. So it remains to be seen whether this drug will be studied in future trials. It's certainly possible that there may be an effect here, but it's obscured by the fact that some people, their skin score is not changing, or their placebo effect is stronger. So that again is one of the difficulties in sort of selecting the right group of patients to enter and to study in these clinical trials. Another drug that's very interesting is called tocilizumab. This drug is FDA approved to treat a number of conditions, most notably rheumatoid arthritis, some forms of vasculitis, giant cell arteritis, for example. And this drug works by blocking a molecule called interleukin-6 or IL-6. And there's been, going way back, longer than we would like to remember, I think, interest in IL-6 in scleroderma. It sort of was not picked up on as soon as it probably should have been, but by blocking IL-6, one may potentially decrease the amount of fibrosis in patients with scleroderma. So this study was again a large multi-center phase 3 trial, double-blind and placebo-controlled trial. And again, the primary endpoint was the skin. And unfortunately, they did not meet the primary endpoint. In other words, they did not show a difference in skin score between those who received tocilizumab and those who received the placebo. And I think this probably may not say as much about the drug itself, but it may say more about the skin score and whether we should be using other markers, other ways of assessing drugs for their effectiveness in scleroderma. And there now is a movement afoot to not just look at the skin score, but to use a composite of several different scores: skin, lung, patient global assessment, and physician global assessment, in order to determine if a particular drug might or might not be effective. Now, one of the secondary endpoints in this clinical trial was the forced vital capacity. So one of the pulmonary function measurements that we look at. And there was a suggestion that in patients who had elevated acute phase reactants, in other words, evidence of inflammation judged by some blood test, that if they got tocilizumab, their lung function was preserved more so than people who got placebo. So I think the investigators are working with the FDA to develop another clinical trial that's going to look at this medication, tocilizumab, to see if it might be an effective treatment for lung disease in people with scleroderma. So the skin score, the trials looking at skin as the primary endpoint have been disappointing in the last few years, but we have had some suggestion that some of these drugs might be effective for other manifestations, including lung disease. So as you know, heart and lung disease is a major cause of concern for our patients with scleroderma, leading to a lot of symptoms and potentially shortening survival. So the good news here is that there has been progress made in the last 12 to 18 months as it pertains to lung and heart complications of scleroderma. So whereas we haven't made a lot of progress in terms of the skin manifestations, we have gone forward in terms of heart and lung problems. So this is probably the most significant study to be done in scleroderma for many, many years, or to date. And it's called the Census Trial. It was published in the New England Journal of Medicine in 2019. The second author of this study was Kristen Hyland, who was a former member of our division at MUSC and now is at the Cleveland Clinic. So Census stands for Safety and Efficacy of Nintedanib, the drugs being studied, in systemic sclerosis patients with interstitial lung disease. Nintedanib was approved by the FDA about 3 years ago or 4 years ago now for patients who have idiopathic pulmonary fibrosis, IPF. And for patients with IPF who are treated with this drug, their decline in lung function or forced vital capacity is slowed down when treated with nintedanib. So the Census trial was designed to look at the same drug in people with scleroderma who had pulmonary fibrosis or interstitial lung disease. And it was a major undertaking. More than 550 patients worldwide studied, so by far the largest study ever conducted as a clinical trial in people with scleroderma. And the data are shown here on the left. I've lost my arrow for some reason. There we go. So here we're looking at the lung function, the forced vital capacity over 1 year, 52 weeks. And you see that both patient groups had a decline in forced vital capacity, but the decline was less in the people treated with nintedanib in the dark blue compared to the people who received placebo. And if you look at the same patients over time, starting when they started the study at time 0 and out here to the right at week 52, you can see that by 12 weeks of treatment with this drug, nintedanib, the two groups start to separate. So you see the nintedanib treated patients have a slower decline or lower slope of decline in lung function compared to the people in the light blue who received the placebo. And you can see that clearly these two groups are different at 52 weeks, following 52 weeks of treatment. I just want to mention the fact that there are some side effects associated with this drug. They don't appear to be any different in scleroderma patients than in the people who are treated with this drug for idiopathic pulmonary fibrosis. And the major side effects are GI, gastrointestinal effects. So as you can see, 75% of the people receiving this drug had diarrhea, compared to only about 32% of people on the placebo. And the weight decrease as a result of this, diarrhea and other GI complaints, about 10 or 12% had significant weight decrease when treated with nintedanib, compared to only about 4% in those who received the placebo. So this is not an easy drug for all people to take, but nevertheless, it has been approved by the FDA. And this was a major breakthrough for those of us who are treating patients with scleroderma who have pulmonary fibrosis. The other drug, there is another drug that is antifibrotic that is approved for patients with idiopathic pulmonary fibrosis. And that drug is called pirfenidone. And we are part of a large study done here in the United States called Scleroderma Lung Study 3, or SLS3. And this study is ongoing. We originally planned to enroll 150 patients. Half the patients were going to get CellCept. Many of you probably are on CellCept, but everybody in this study was going to get CellCept. Half of them were going to get an additional placebo. The other half were going to get this drug, pirfenidone, in addition to their mycophenolate. And these patients were to be followed for 18 months. And we're looking at their lung function as the primary endpoint with some other secondary endpoints as well. Unfortunately, due to the COVID pandemic, enrollment was slow, and the sponsor has decided to curtail this study. So the enrollment is now closed, and I think we have 25 patients in each group. So we're far short of our anticipated enrollment of 75 patients in each group, but we do hope that we will have sufficient number of patients to make some judgment about whether treating patients with scleroderma who have interstitial lung disease or pulmonary fibrosis, treating them with CellCept or mycophenolate plus this antifibrotic pirfenidone up front as a combination therapy, whether that's going to be successful or not. The other thing that just came out very recently in the New England Journal of Medicine is a treatment for pulmonary hypertension in people who have interstitial lung disease, including patients with scleroderma who have interstitial lung disease. So some patients who have interstitial lung disease will also develop pulmonary hypertension. And it's been rather unclear whether the pulmonary hypertension drugs that are available are effective in those patients. And this is the first study to really look at one of those drugs carefully. And that's a drug called treprostinil. And in this particular study, it was delivered by inhalation. So 4 or more times a day, inhaling this medication. And this study was a positive study. And it showed that patients with interstitial lung disease who, as a consequence of that lung disease, had developed pulmonary hypertension, they improved with this inhaled treprostinil therapy. Brand new study, not yet FDA approved, but I'm sure it will be in the near future. Just a few words about the GI tract. There's not a lot of research being done on the GI tract, which is unfortunate because so many of our patients have GI symptoms. But I thought this was an interesting study that was recently published. Many patients have what's called small intestinal bacterial overgrowth. So they'll have episodic diarrhea, bloating, sometimes significant weight loss. And in this particular study, they treated patients with a gut bacteria, a probiotic, and an antibiotic, metronidazole or Flagyl. And they showed that this combination of a probiotic and an antibiotic, in particular metronidazole, was in fact effective in treating small intestinal bacterial overgrowth. So if you have this problem, your physician may not be aware of this study, please bring it to his or her attention. And another interesting study that I haven't read in detail yet, but there are such things as fecal transplants for people whose microbiome or gut flora are majorly disrupted by the disease process. And this was a study that showed that some patients' GI symptoms could be improved by a transplantation of a normal fecal bacteria. I won't dwell on the vascular studies other than to mention this study, which is ongoing at MUSC and elsewhere around the United States. Enrollment is going to end in March. I think we enrolled a patient this week, and Dr. Ed Smith is the site PI or principal investigator for this study. So we're hopeful that this study will be positive and it will enable or bring forth a new treatment for patients who have severe Raynaud's phenomenon with those digital ulcers or gangrene of the fingers or toes. And finally, in terms of complementary and alternative medicine and advances there was this study that was recently published looking at a Tai Chi exercise program in patients with scleroderma. And in this study, which was a relatively small study, they did show or were able to show that Tai Chi exercise improved endurance, balance, sleep quality, fatigue, anxiety, and depression in their patients. And I thought I would end with this because I was thinking that perhaps some of our study groups might want to invite somebody who's an expert in Tai Chi to meet with our patients and discuss ways that they could get engaged in this form of exercise that might be beneficial for them. So I've lost track of time. I hope I haven't gone over. And I've just given a very quick overview of what's been going on in the last 12 to 18 months in terms of treatment for scleroderma. And I would be happy to answer any questions that you may have.
Thank you, Dr. Silver. Dr. Hant. Dr. Hant is going to talk with us about the COVID vaccine. She's an associate professor in rheumatology and immunology in the College of Medicine at MUSC, and she's the director of rheumatology and the Rheumatology Fellows Program. We are excited to hear what Dr. Hant has to share, but remember, mute your microphones, mute your video. Sometimes we do want to warn everybody, sometimes we try to protect you because we're recording. So if you're eating or something, just be careful that you're on camera, be careful. So we might mute your camera. Don't be surprised. We're doing that so that you won't be uncomfortable later if you see that in a recording. But I'm delighted to have Dr. Hant join us. I'm going to unshare my screen so she can jump in here. So this is my doctor, and I always appreciate how she's so patient with me. I appreciate it. So I'm going to let you take it away. Do you need anything as you get set up?
I don't think so. I'm just gonna, thank you, Karen. I'm just gonna see if I can pull up my slides here.
No, that's the hardest part, right? The share screen.
Yes, let me do this.
All right.
You able to see that?
Yes, we are.
Okay.
And you can use presentation view. Yep, there we go. You're set.
There we go. Awesome. Well, thank you, Karen, for that lovely introduction. And I very much appreciate the opportunity to speak to everyone this morning. So this is really a moving target. You can imagine not only dealing with the pandemic as humans and people, but also the amount of information coming at you. So I'm sure there's going to be lots of questions. And I did receive a nice list of questions that I've tried to address throughout the talk. So hopefully I will answer or will have answered some of the questions that were posed. All right, so I'm going to move forward. I have no disclosures. So when we talk about risk to patients with scleroderma and COVID disease, the data are somewhat variable. There's not clear evidence at this time that scleroderma patients are at increased risk specifically for COVID, or that they'll develop more severe disease. There's also no strong data that immunosuppressants make patients more susceptible to COVID or severe manifestations. Thus far, the only strong data we have is that prednisone doses 15 milligram or above may increase risk for COVID and severe disease. Luckily, in systemic sclerosis, we don't typically use high doses of steroids above that due to risk for things like scleroderma renal crisis, but just something to be aware of. And then the new variants, so the South African, UK, Brazilian variants are sort of unknown at this time. We certainly know they're more contagious. All right. So talking about overall recommendations, really need to be following the CDC guidelines. If you haven't been to the CDC website, there's just a wealth of information on there for patients and providers. So clearly you've been doing this the last year, but always wearing a mask, both indoor, outdoor. Anytime you're with individuals in an enclosed space, make sure the seal is tight over the nose, washing your hands frequently, cleaning surfaces, not dining indoors at restaurants, and certainly even outdoors if you're uncertain about social distancing, and if the waiters and cooks and other people at a restaurant are not wearing masks, that could be an issue, certainly. Having friends over, distant family members, you just don't know who may be carrying it. Sometimes younger children or other folks may be asymptomatic or have very mild symptoms. We do know that gyms appear to be a risk, a place of risk, if you will, just because people are taking their masks off. So trying to avoid a gym or crowded locker rooms, etc. Religious facilities may also be an area that you may be in closer contact with people. And so making sure the air system is good, and obviously wearing masks and social distancing whenever you can, taking measures to do takeout, grocery store delivery, etc. And luckily we don't need to stock up on toilet paper like we did last year. So what do you do if you are exposed or have symptoms? So if you're exposed and you're asymptomatic, you should wait about 2 to 3 days post-exposure and get tested whether you're symptomatic or not. And you should really be sort of quarantining yourself during those 2 to 3 days. If you're symptomatic, no matter what symptoms you have, don't just pass it off as a common cold. Testing positivity is over 25. And if you have a fever, the chances are greater that it could be COVID. So it would be a good idea to go and get tested. If you have a positive test, and we're going to go into specific immunosuppressants in more details in a few slides, but you should stop taking your immunosuppressants, but continue your Plaquenil, low-dose prednisone, and your other medications, like if you're on blood pressure medicines or thyroid medicines, those kind of thing. And if you have a positive test, you should immediately contact your primary provider as well as your rheumatologist. If you're mildly symptomatic, you should be quarantining yourself for 10 days. You may need the monoclonal antibody infusion, and that should be discussed with your primary provider. There's a set of eligibility criteria that can be used to determine if that's a treatment for you. If you're having breathing issues, you should go and be evaluated to the emergency room, especially to evaluate your pulse oximetry levels and your oxygen levels. They may not admit you, but they may give you something called dexamethasone or other treatment. We know that from the convalescent plasma or this monoclonal antibody infusion, it may benefit patients that are hospitalized with COVID-19 when given early in the course of disease, or if the patient's own immune system is not able to make their own antibodies to the virus. Studies have not shown benefit when it's given late in the course of disease with severe COVID. So people that are, for instance, in the ICU. And although thousands of people do and are affected by the virus, we've learned ways to treat them to decrease mortality, even if patients are critically ill. And there's some newer data showing drugs like tocilizumab, which Dr. Silver mentioned for in his talk, that may be helpful. I just want to direct you and let you know that there are some nice videos, and there's information on the Scleroderma Foundation page that were created by the Medical and Scientific Advisory Board. So make sure that you look at that as well. And I'm going to sort of switch gears a little bit and talk a little bit about the vaccine. So the ACR, Scleroderma Foundation, CDC, and NIH all recommend that scleroderma patients, whether on immunosuppressives or not, get the vaccine. At this point, there's really no evidence that when you get the vaccine, it will lead to a scleroderma flare. And there's not great evidence or anything to suggest that you are more likely to have an adverse reaction if you have scleroderma and get the vaccine. Rates of allergic reactions, which I know a lot of folks have heard about, are pretty rare, and I'll talk about that a little bit more later. And you want to make sure you get both shots, as it significantly increases your immunity. And there's no evidence to suggest that patients with scleroderma respond less well, although there is potential concern that some of the immunosuppressants may blunt the immune response to the vaccine. So what do you do about your immunosuppressants and biologics? So we're lucky in that just about 10 days ago or so, the American College of Rheumatology came up with a guidance summary to use on patients who have rheumatic and musculoskeletal diseases. So I just want to point out that this is guidance. These are not meant to supersede the clinical judgment of a patient's doctor and the patient-doctor relationship. So at the end of the day, we can use these guidances, but we really need to be talking to our provider who knows you best, knows the ins and outs of your disease and what medicines you're on. So the general considerations are that, your rheumatology healthcare provider is responsible to engage you in a discussion, to assess your vaccine status, and sort of share decision-making about getting the vaccine. It is known that autoimmune related disease can be at higher risk for hospitalized COVID-19 compared to the general population. Beyond known allergies to vaccine components, there are no known additional contraindications to autoimmune disease patients to get the vaccine. Okay. And again, I alluded to this earlier, there is a theoretical risk that scleroderma could flare, but the benefits of getting the vaccine outweigh that extremely rare risk. So further recommendations are that, again, you should receive the COVID-19 vaccine. Based on the data we have for the 2 available mRNA vaccines, there is no preference for one or another. You should get whatever vaccine is available to you. Following the vaccine, patients should continue to follow all the same public health guidelines, including social distancing and other preventable measures. There's been questions about, well, how do I know that I respond to the vaccine? And should I have antibody levels checked after I get the vaccine? And the recommendation is that healthcare providers should not routinely order lab testing to assess immunity post-vaccine, nor to assess the need for vaccine in an unvaccinated person. Household members and other frequent close contacts should get vaccinated when it's available to them. And there's not a priority for early vaccination for household members for patients with scleroderma. And while vaccination would ideally occur in the setting of a well-controlled autoimmune process, unless you have life-threatening illness, for instance, you're in the ICU, you should really be vaccinated as soon as you can, irrespective of your disease activity or severity. Okay, so this is a chart that sort of discusses certain medications as well as vaccine timing considerations. So these are, again, based on well-controlled disease to allow, in some instances with certain medications, a temporary interruption in those medications. Again, these are general guidance recommendations. So even though I'm telling you these things, it's really something that you should discuss with your specific provider to make sure that they want you to stop your medicine. So always talk with your rheumatologist. So if you take hydroxychloroquine or Plaquenil, IVIG, and prednisone or its equivalent, less than 20 milligrams a day, there should be no modification to those medicines, nor to the timing of the vaccine. You just can get it. Same thing with all those medicines listed below that. So things like leflunomide or Reva, Imuran, Cellcept, which many of you may be on, oral Cytoxan, no modification to those medicines, nor the timing of when you get the vaccine. If you happen to be on methotrexate, the recommendation is to hold the methotrexate 1 week after each vaccine dose. And again, talk with your rheumatologist. If you're on a JAK inhibitor, for instance, if you have a rheumatoid arthritis overlap, those are things like Xeljanz, Rinvoq, and Olumiant. You would also be holding that a week after each vaccine dose. If you're on a Batacept, which is Orencia, there are also modifications based on if you take an injection versus the IV form, which you can see there. If you're on IV Cytoxan or cyclophosphamide infusions, that will also may need to be timed. And if you're on rituximab, because of how rituximab works as a B-cell depleting therapy, we would try to schedule the Rituxan so that the vaccine series is initiated 4 weeks prior to the next scheduled dose. So if you were due to get your dose on May 1st, we would try to vaccinate you April 1st, get your second vaccine, and then wait a couple weeks later to get your Rituxan. So if you're on any of the medicines listed in this chart, the take home is talk with your doctor and they can advise you on exactly what to do if possible. Now you might say, well, gosh, I didn't know this and I've already gotten my vaccine and I'm on one of these medicines. That's okay. Any response, we hope that even if you didn't hold these medicines, you will still have an immune response and be protected. All right. So other miscellaneous information. At this time, getting the vaccine does not have any impact on clinical trials that are currently ongoing or planned, and there's no reason to suspect it'll have any more effect than the flu vaccine. There is also not a lot of data on pregnancy or breastfeeding. Because being pregnant is a risk factor for more severe disease and increased mortality, it is recommended that pregnant women get the vaccine. But again, this would be a discussion between the obstetrician, the rheumatologist, and the patient. So talk with your healthcare provider. So just to discuss a little bit about the vaccines, the Moderna and Pfizer, which are a series of 2 shots, either 4 weeks apart for Moderna or 3 weeks apart for Pfizer, have really robust effectiveness, about 95%. Very close for Johnson & Johnson, which is 1 shot, 70% effective. And then AstraZeneca is also pretty close, about 80% effective, but appears to be not as effective against the South African variant of COVID. So how do these vaccines work? So all of the current vaccines in development or currently not FDA approved, but used for emergency use authorization are based on this a new technology for vaccines. And they use mRNA or messenger RNA as the primary deliverer of immunity. mRNA is the genetic material that contains instructions for making proteins. And so I don't know if you can see my pointer, but this little cartoon basically goes through with how these work. So you can see here that we focused on the genetic sequence for this spike protein that's on the virus. This is used to synthesize an mRNA sequence or instructions that the cells will use to make the spike protein. Then that is put or packaged into this lipid nanoparticle that will deliver instructions to the cell. It goes into the cell, but does not go into the nucleus, so it doesn't affect your DNA in any way. And once inside the cell, it uses it's the cellular machinery to produce the viral protein. This then is displayed on the surface and initiates an immune response. And so if the body is then affected by COVID, the body will know and produce antibodies against the virus. Again, 3 different types of vaccines in development: protein-based, which don't seem to work; viral vector and mRNA, and the mRNA ones are the ones we just discussed, and those are the Moderna and Pfizer that are EUA available, or emergency use authorization available. So after you get the vaccine, be comforted that you're about 95% protected against getting symptoms from the virus. Be comforted that you're 100% protected against serious disease and death. It's not clear if you can get infected and spread the virus while being asymptomatic, but likely you cannot transmit it once you have full immunity, but we don't know. You still will need, once you are vaccinated, to wear a mask and keep the same precautions until we've reached this sort of herd immunity. And remember that you still have a 5% chance you could get the virus. So again, the reason that we want to still take precautions. But once vaccinated, it would be good to be able to see your kids and grandkids, and then obviously following travel guidelines and international guidelines for travel, which are changing all the time. So I know when I first came in, I heard folks saying, oh, I've gotten my first vaccine, and you're going to be getting your second vaccine. This is a very nice little cartoon about what to expect after getting the vaccination. Most people feel pretty good after the first vaccine, maybe just some arm pain or discomfort. Most of the reactions, if you will, happen after the second vaccination, where you may have pain in the arm, you may have some swelling in the area, you may feel like you have the flu. And you may even feel like, you're not able to do what you need to do in terms of fatigue and things like that. But that really depends. Some of my colleagues, we've all been vaccinated now, really had nothing after the second vaccine. I can tell you, after my second vaccine, I felt like I had the flu, and I got my second vaccine purposely on a Saturday so that on Sunday I could have a day to recover, if you will. So consider planning accordingly. When should you call your doctor? In most cases, again, discomfort or pain will be normal. If you have redness or tenderness that isn't getting better after a day or so, you should reach out. And any side effect that worries you, you can certainly touch base with your doctor. Okay. And then there is this nice cdc.gov vSafe, where you can tell the CDC about any side effects after the vaccine, and they'll also send you reminders about the vaccine. So a nice little thing that the CDC provides. I just wanted to put this up because I know folks have a lot of concerns about vaccines in general. So again, can a COVID-19 vaccine make me sick with COVID-19? No. None of the authorized and recommended vaccines contain live virus that causes it, and so it cannot make you sick with COVID-19. Will it alter my DNA? We talked about how this is an mRNA vaccine, and that does not change or interact with your DNA in any way. If you've already had COVID-19 and you've recovered, do you still get vaccinated with the vaccine? Yes, you should. And that's because we don't know how long you're protected from getting sick again if you've recovered. And so you should be vaccinated if you've had COVID and recovered. And is it safe to get the vaccine if you want to have a child someday? Yes, you should. Based on current knowledge, it's unlikely to pose risk to a person trying to become pregnant in the short or long term. COVID-19 and vaccine and allergic reactions. So these are extremely rare. I just wanted to have a slide about this more for reassurance than anything. There are safeguards in place. when you get your vaccine, you should be monitored on site. The biggest concern is if a patient has had an allergic reaction to a vaccine in the past and components of a vaccine, those are the patients that there could be concern. So if you've had a history of a severe allergic reaction or any immediate allergic reaction to a vaccine, you should be monitored for at least 30 minutes. All other patients should be monitored 15 minutes after the vaccine. They should be able to handle an allergic reaction wherever you're getting the vaccine. And if you, God forbid, have an allergic reaction, you should receive care and emergency services. The CDC says that if you have an allergic reaction to the first dose, you should not receive the second dose. And the CDC recommends that if you have severe allergic reactions not related to vaccines or injectables, such as food allergies, pet allergies, latex allergies, you should get vaccinated. If you have allergies to certain oral medicines or family history of severe allergy, you should get vaccinated. I don't know why that little star is there. Sorry about that. So these are the phases of vaccination in South Carolina. And we're currently here, which is ongoing at this time. So certainly healthcare workers, long-term care facility residents and staff, admitted hospital patients over 65 and older with or without underlying health conditions. And so we're learning more and more about COVID every day. If you go to the phase 1C section and click on these underlying health conditions, this is not an exhaustive list. There are conditions that they list as known for increased risk for severe illness from COVID. So those are people that are, for instance, smokers, obese, have COPD or cancer as an example. And then there's another list that lists conditions which might be at increased risk for severe illness. And it's under that list where you have patients with immunocompromised states, on immune suppressants, patients with pulmonary fibrosis as an example. And so I do believe that many and most patients with systemic sclerosis will be falling into this phase and would be eligible to be vaccinated. And at the end of the day, again, just talk with your doctor and they can advise you. Getting the vaccine, so actually going to get the vaccine, don't rely specifically on one source. Certainly MUSC, Roper, Prisma, and the DHEC website and the South Carolina DHEC website are great resources to see and sign up for vaccination. I've listed at the bottom the website for the MUSC vaccine program where you can sign up, as well as a phone number if you're wanting to get vaccinated at MUSC. There are also satellite locations, I believe, in Florence and Lancaster as an example, where you can get the vaccine as well. Again, there's first come, first serve sites, and because of the storage needs with Pfizer, and they have to be stored at such a low temperature, it's really felt like those are really going to be done through hospitals. Johnson & Johnson vaccine may make it to individual sites, and the good news is that more and more Americans are getting vaccinated. And this was just something I pulled off yesterday that shows the total number of vaccine doses administered as of February 19th. And I think South Carolina is here. So we're at 848,054 vaccines administered. So I would encourage everyone to be vaccinated and talk with your doctor about other specific questions. And I hope I didn't go over, I might have, but I just, again, wanted to thank you for your attention and for letting me talk with you.
For our next presentation, get me geared up here, we have Dr. Carol Fegahli-Bostwick, who is going to talk with us today about, get here, some of the research going on in her lab, as well as share with us a lab tour. So we are delighted to have Dr. Carol here with us today, and she is a professor in rheumatology and immunology in the College of Medicine at MUSC, and she is the Kitty Trask-Holt Endowed Chair for Scleroderma Research. So we always love having her share information with us because I know I learn a lot, and it's also exciting to hear what's going on. I always come away feeling very encouraged. So welcome, Dr. Carol Fegahli-Bostwick, Dr. Carol, and thank you so much for being with us today. And I'm going to hand over the screen to you. Oh, I love your background. That's great.
You know, you're a scientist, you got to have a science geeky background.
Yeah, that's fabulous.
Good morning, everyone. All right, let me start out as I pull up my slides and share them. Let me start out by expressing my gratitude to Susan, Karen, Francis, Melody for an amazing organization of last Saturday and this Saturday. But to them, to the support group leaders, to the volunteers of the South Carolina chapter of the Scleroderma Foundation, I want to express my gratitude for you so generously giving of your time to support other patients with scleroderma and their families. I also want to say a special thanks to Dr. Silver for his many, many years of genuine and unwavering support of the Scleroderma Foundation. So let me know once you actually can see my slides. I already shared, there might be a lag.
We can see them.
Okay, perfect. I need to just move this so I can do the PowerPoint share. Here we go. So I decided to start with the lab tour. And I'm going to do a laser pointer that you will see here to point to things. And then go on to sort of an update of what we've been doing in our research in my lab. So as you all know, this is the beautiful Ravenel Bridge that I cross every day on my way to MUSC on a sunnier day. All right, why is research important? And some of you may have seen this before, is because the research that starts out in our labs, in academic institutions, is the research that ultimately leads to discoveries, and these discoveries down the road get developed into therapies. And that's why starting at this stage is critical, because without this research, it would be impossible to get to the therapies. So we're going to start with a tour, and we're starting, it's hard to see what these are, but you'll realize soon, we are in the elevator of the clinical science building elevator, and we are going up to the 9th floor, which is where my research lab is. Dr. Silver's research lab is there as well. And we're going to start with getting off the elevator. So we're going to do it phase by phase. Oops, that didn't work too well. Let's try it again. It does not want to start. Francis, any suggestions? It's a little embedded video.
Oh, Francis, can you help Carol? Because I think she may have to go out of that browser like I had to do for the time.
Right. Is it embedded through an online link or a video on your computer?
The video on the computer.
Okay. There should be a little play button for you to press.
It's not showing up. It showed up when I practiced it. But once I got to Zoom,
that's what happened to us too.
The only thing I can think of as a really quick fix is to share the original video on your computer. I know that's a bit of a pain to switch in and out of screens, but
let me try it this way. Here we go.
Oh, there it is.
Yay.
So we are coming off the elevator, and this is how you initially see the research labs. And we're going to go down to the left, all the way down the hallway. Those of you who have done the lab tour have had to do that. You come off the elevator, you go down all the way down the hallway, and my lab is towards the end on the right. All right, and then once you get to the end of the hallway, this is sort of where we are. And this is as you go into the lab. So you can see the benches, the shelves that have our reagents and chemicals. There's desk areas straight ahead where everybody can sit and analyze their data and prepare their PowerPoint presentations. And then now we're going to go straight down the hall to where we do our cell culture, because I want to talk to you a little bit about the assays we do, how we do them, where we do them. This is first of all our freezer room. This is where all the samples are stored. And these are what my husband calls the R2D2 units, where we freeze cells. Okay, so we're going to go over them. So for those of you who have taken one of the tours, this is from one of the tours. I'm going to go back and do, I guess, the laser pointer again. Here we go. We had different types of freezers as we walked into the room. One is a minus 20 degrees Celsius freezer. That's what you all have as a freezer at home. Minus 20 Celsius is equivalent to about -4 Fahrenheit. So typical freezer that you keep your food at home, we keep certain reagents in it. These large units here hold temperature at -80 degrees Celsius, which is equivalent to about -110, 112 Fahrenheit. So again, very cold temperatures where we have to keep reagents to keep them safe. And our R2D2 units, where we keep the frozen cells, are at -140 Celsius, which is equivalent to -220 Fahrenheit. And the reason is, as we grow cells from tissues, for example, if you get a skin biopsy for research, we can grow cells called fibroblasts out of it. Those fibroblasts can be frozen at these low temperatures in these units in liquid nitrogen. These are the liquid nitrogen tanks that feed into the freezers. And what happens is that anytime we need them for our research, we can pull them out of the freezer, thaw them, grow them again. They're alive. They stay alive under those conditions because they're frozen in a very special solution. And then we can use them for research again and again and again. So a skin biopsy and fibroblasts will end up contributing to a lot of research projects and years worth of research. And these are the cells that we grow. They're called the fibroblasts. We call them the main effector cells in fibrosis because ultimately they are the cells that make the excessive collagen, fibronectin, other proteins that cause the thickening of the skin and internal organs in scleroderma. And under the microscope, this is what they look like. So we get a skin punch biopsy, we grow the fibroblasts. Initially, this is what they look like. There are these spindle-shaped cells that connect, sometimes grow next to each other. They like to grow close together. Actually, they give each other growth factors to help each other grow. And then when they get really packed on a plastic dish in the lab, they become like that, like a carpet of these spindle-shaped cells basically all over. And those are the cells that we use in the research in my lab. There are other cell types that are used by other investigators in the field. You know, if people are looking at blood vessels, they might be using a cell called endothelial cells. But for us, we mainly focus on these fibroblasts. And these fibroblasts are grown in these, what we call incubators. They're chambers that are humidified, have 5% CO2, and where the temperature is maintained at 37 degrees Celsius, which is our body temperature, so that the cells imagine as if they are still remaining inside the body. The work that is done with the cells is done in these chambers we call tissue culture hoods. It's a sterile environment. You can kind of see a bluish purplish hue. That's because there's a UV light in there. When we are not using it, we turn the UV light on. The UV light on will kill any viruses, bacteria, anything. The key is we're not trying to protect ourselves, but we're trying to protect the cells that we do for research so that they are not contaminated by spores or bacteria or anything else. Because once they are contaminated, we have to discard them. So this is a way of keeping our work sterile and keeping those cells nice and safe and clean. So this is a previous member of the lab, Dr. Tomoya Watanabe, who was a physician scientist from Japan who came to the lab to train for a couple of years. And he's doing experiments inside one of these chambers. So you can see once you're working inside and you have cells inside and your hands, you switch the UV light off and you turn a regular light on. And that allows you to see what you're doing without being exposed to the UV light. And there's a screen that closes almost all the way. It just allows enough room for your arms to go in to do the work. And that way, again, the airflow that's in there maintains a sterile environment for the cells. Here's another angle of him working in it. And we have two of these side by side, and here he is working in one. This is Dr. Deanna, for all those who know her, working in the other one, so two side by side. And I mentioned the cells are kept in this incubator, but what we keep them with is they grow on in these plastic containers. The fibroblasts are cells that like to stick to a surface. So they stick to the bottom of a dish or a container that has basically wells or multiple dishes in it. They grow in these flasks. And what you see as pinkish, reddish liquid is from this bottle. This is the medium that we use to grow them. They can't grow dry without any liquid. They need liquid to keep them growing, but also to give them the nutrients they need. So this medium has vitamins, amino acids, glucose, all the nutritional things that the cells need to be able to grow. Here's another view. And this is a close-up. These are pieces of tissue. In this case, we use these pieces. For example, each one of your skin biopsies were about the size of one of these pieces, and we put them in the dish and allow the fibroblasts grow out of them. The cells actually grow out of them. They migrate out of the tissue, spread all over the dish, and they multiply and divide to fill the dish. And again, as I mentioned, we grow them in these incubators that are body temperature. When you open the door to the incubator, this is sort of what it looks like. You have dishes, you have flasks that I showed you, and all have this pinkish reddish medium that's nutritious for the cells. All right, what do we do with these cells? One of the things we do is we look at RNA in the cells, we look at protein in the cells, so we extract the RNA and the protein. This is an imager that we use, and on it you can image how much protein there is across different cells from different individuals or under different experimental conditions. The proteins are usually separated on what we call gel electrophoresis. This is Sinsen Yen. She's actually now Dr. Yen because she was a PhD student at the time of this tour. And in December, she defended her thesis and got her PhD. But she is putting protein samples, loading them on this gel, which separates them by size and then allows us to visualize them on this imager. All right, we do a lot of our testing in human tissues in my lab. This is not typical of a lot of labs, but we do it because, as I've shared with you before, I know we can cure just about anything in mice. The challenge is, as you're developing therapies that might work for scleroderma, are they likely to be effective in humans? Because humans are not like mice, and you want to make sure that something's going to work in a human tissue, not just in rodents. So what we do is we test many things in actual human skin. This is skin that we get that's discarded after tummy tuck surgery. The top layer that you see in the skin, this is actually a fatty layer that we get rid of, like here. And this is Dr. Yamaguchi, who used to be in the lab. After trimming the fat off, we use the top layer of the skin. This is the top layer of the skin right here. And these are examples of several pieces. And what we do is we take them and we put them in the pink fluid that has the nutritional materials for the skin, but we keep the top layer of the skin known as the epidermis exposed to the air because that's how it is normally on our body. It's exposed to the air. And then the inner layers of the skin are exposed to this nutritious media. And what we can do is we can inject things into the skin that cause fibrosis and watch how it changes and how the skin becomes thicker, and what genes it may turn on or turn off in the skin. And we can inject things that we think are potential therapies and then look to see if they can counteract the effects of the agent we injected that causes fibrosis. So this is Logan. Many of you might have met him. He spent several years in my lab before getting his MBA and changing from a research career. He volunteered in almost every single year of the local in-person education program that the South Carolina chapter put on the MUSC campus.
One of the assays we do is a human skin ex vivo.
Can you guys hear that?
What we do for that is obtain tissue from
It's faint.
Okay, so maybe what I'll do is I'll speak over Logan so you can hear it a little better. What Logan's going to show you how we do the punch on this skin in the actual lab. So this is what it looks like. And we can do just like you do a skin punch in the clinic, your doctor does it to grow the fibroblasts. We can do the same thing in the lab on the skin that we get from tummy tuck. So you're going to watch him do it. He has this punch, which has a circular blade at the end, and he can punch literally a circular piece out of the skin to use in the experiments. And now he's showing you what he got out of it, basically.
Into a 6-log dish where we can further treat.
All right, and this is what the skin looks like. So if we take a very tiny micrometer thick section of the skin and look at it under the microscope, this would be right here, the upper layer of the human skin, the epidermis, and this would be the inner layer of the skin, the dermis. And this is a skin that was treated with a vehicle or a control. Sometimes that's just saline or something very just that we use as a carrier, basically. And this is skin that was treated with an agent that causes fibrosis that we identified in the lab as causing fibrosis. And this one, it's insulin-like growth factor binding protein 5. It's also called IGF-BP5. But you can see that after a week, so we inject this once, and we wait a week, and then we harvest the skin and section it and look at it. You can see just with the naked eye, you don't need to do exact measurement, that the skin got much thicker when we injected the agent that causes fibrosis compared to using just the carrier of that agent. And you can tell if you look at higher magnification. So now we're doing a close-up into this part of the skin, the dermis. You can see that also these pink things in the dermis, these are the collagen bundles. These are the collagen bundles when they assemble together. And you can see that they also got much thicker compared to really thin lines here, the thin bundles you see in the control skin. So that's one way how we assess things in skin. Another way we do it is we also assess agents that can promote lung fibrosis in human lung tissues and agents that can prevent or even reverse fibrosis in human lung tissues by doing a very similar approach. So we get a human lung, in case this is actually a scleroderma lung from a patient who underwent lung transplant surgery, and we got the lungs for research purposes. This is actually me holding the lung. What happens is you can cut up the lung into pieces and test the pieces as an organ in the lab for agents that can cause fibrosis and agents that can mitigate fibrosis. And this is when you start cutting it up, what it looks like. These are the smaller pieces we use to grow the fibroblasts out of them. So you make them stick to a plastic dish, add the pink medium, and the fibroblasts just start migrating out of these tissues and they start growing and filling up the dish. We also do a lot of imaging of our studies. This is a microscope that we use to detect signals in tissues. So for example, here, the section, the slide with the thin section I showed you of the skin earlier, for example, or lung is placed here and you can image it. This is an image of a lung. You can see there is fibrosis because of these areas that show there is fibrosis. So you can do, this is what's called an H&E stain. That to look at just histology, you know, where are the cells, where is their matrix or deposited. This is immunofluorescence. You can see there's fluorescent colors, green here, red here, and that's a way of detecting specific proteins. In this case, you can see this green is identifying a fibroblast that has enlarged, become wider. This is what happens when they get activated and they become myofibroblasts. The blue is a way of us detecting the nucleus of each cell. So each blue circle is a nucleus of a cell. So that's how we start imaging, you know, which cells are there that are being activated? Are they making this protein that now we've marked with red color? Are the cells that are green making the red protein or other cells? How many cells do we have? So it's one way of analyzing what's happening at the cell level and the tissue level in this, on this microscope. All right, so that covers some of the features of the lab tour. Obviously, when you get to do it in person, you get to see a little more, and hopefully we'll be able to do that next year with everybody who would like to come see the lab. I want to switch over a little bit to tell you, I want to be conscious of the time too, to tell you about what we've been doing over the past year in the lab. So the pandemic affected everybody. including the research labs, because early on in March, when we had to close down the labs and take precautions, it was a little hard to continue the research, but we tried to use our time for publishing our findings, so writing manuscripts and also for writing grants. So we continue our research on solving the fibrosis puzzle in scleroderma. And I want to tell you about some of the studies that got published in 2020, and then very briefly, the studies that are ongoing that are on track to be completed in 2021. So some of our studies involve this family of molecules, the insulin-like growth factors. These are insulin-like growth factor 1 and 2, and the proteins that bind them, insulin-like growth factor binding proteins 1 through 6. So many years ago, when I started doing research as a faculty, as a postdoc and as a faculty, those were the initial proteins that I identified as being expressed at abnormally high levels in scleroderma patient tissues, but that can in turn turn around. And if you experimentally put them in mice or put them in the skin I showed you that we use in the lab, can induce and trigger fibrosis on their own. And we've spent a lot of time trying to figure out how they do that, to figure out how to stop them. So one of the things we did this past year is we made genetically engineered mice, I'm gonna go back and show you, that express this particular one. So when we looked at genes that were abnormally turned on or turned off in scleroderma fibroblasts from the skin of scleroderma patients many years ago, this gene had a 20-fold increase in levels in scleroderma skin fibroblasts, and it was one of the most highly abnormally expressed genes in scleroderma, and it had never been studied in scleroderma or fibrosis. So we've been working on it ever since. So we made these genetically engineered mice that expressed the human gene. And what we found is in the mice that express the higher levels of this gene, the way you would see the levels in scleroderma skin, they develop skin fibrosis. So this is the thickness of the skin in the mice. If they make high enough levels of this gene, human gene, compared to mice that make lower levels of this gene, or mice that don't have this gene in them at all. So this allowed us to show that the levels that we see in scleroderma patient skin are sufficient to cause fibrosis, and that we can recapitulate that in the mice to use them as a model of skin fibrosis. Another study that we completed and published, and you will see this is how they appear when they're published in PubMed. One way for you all to look up papers, publications on scleroderma is through PubMed. Another way is to go through Google Scholar and search for scleroderma as well, and you can see what's recently published. So another study we published was this molecule that we had been working on for years at my previous institution with the chemist who developed it, Dr. Peter Wipf, right here, called MMS 350. And it's a DMSO analog. Some of you may have heard of DMSO, that was initially developed as a radiation mitigator to protect from radiation and protect lung fibrosis from radiation. And it turns out it does reduce lung fibrosis. So if you induce lung fibrosis in mice with an agent we call bleomycin, you can see there's increased matrix content, collagen content in these mice compared to control mice. And then when you add this agent, and we add it in the water of the mice, they drink it. If you add this agent to the mice that receive the bleomycin, you get a reduction in the lung fibrosis. So showing that this molecule has anti-fibrotic properties. So that was another study that we were able to publish in 2020. Yet another study we published was looking at similarities and differences in human lung tissues and the lung tissues of patients with scleroderma who had a lung transplant surgery, comparing them to the lung tissues of patients with idiopathic pulmonary fibrosis or IPF that also had lung transplant surgery, and comparing both of these to normal lung of normal donors. These are donors whose lungs don't get used for transplant surgery. And what we found is we identified not just genes that were abnormally turned on or turned off in the fibrotic lungs, we also identified pathways that some we knew about, some we had overlooked over the years that were recently identified through the study. So we found genes that were unique to scleroderma lungs and were different in scleroderma versus normal lungs, genes that were unique to idiopathic pulmonary fibrosis lungs. But then we identified genes that were similarly abnormally regulated in both scleroderma and IPF lungs, suggesting that if we can target these genes and these pathways, we can be effective at improving lung fibrosis for both of these diseases. One of these molecules, Dr. Silver mentioned in his presentation a little while ago, is interleukin-6 IL-6, which is the target of the drug tocilizumab. IL-6 has been something near and dear to my heart. It's something I worked on as a graduate student and reported the first report of increased IL-6 in scleroderma fibroblasts. So this is coming full circle back to what I worked on as a graduate student. And that was another study that was published. Another study involved lysyl oxidase. You may have heard me talk previous years about this if you attended the patient conference. Lysyl oxidase is an enzyme that cross-links the matrix. So when the cells make collagen and the collagen goes outside the cells, what happens is the collagen has to be cross-linked. Links have to be made to bind these collagen molecules together and form a matrix. Lysyl oxidase is the enzyme that links the collagen molecules and other matrix proteins. And when you have too much lysyl oxidase, you get a lot of cross-linking, and that can contribute to the fibrosis. And that's exactly what we found. We found that lysyl oxidase can promote fibrosis, but we also found something unusual. We found that lysyl oxidase, in addition to working outside the cell at linking these molecules, if you add it to cells, can actually turn on the fibrosis genes, which is a function that had never been reported before for lysyl oxidase. And I'm going to come back to lysyl oxidase a little bit at the end. But so we've identified novel functions for this enzyme that was presumed to work only outside the cell, mainly at linking the matrix. So we found it increased the genes, turning on the genes for collagen, fibronectin, and other key players actually in fibrosis. All right, another project we worked on that's been really interesting to me is, as I mentioned before, we've been trying to compare scleroderma lung fibrosis to other diseases. We want to see what's unique to scleroderma, but also what is shared across diseases that we can target to improve all these conditions. We started collaborating with Dr. Angel, who is in the proteomics laboratory, using mass spectrometry on pieces of lung from adenocarcinoma, lung adenocarcinoma, and normal lung. So this is a adenocarcinoma piece of lung, and this is a normal, and we have them on what we call a tissue microarray. So each piece is from a different individual. And this is all carcinoma pieces, and this is all normal lung pieces. And what we did is we applied this technique that allows us to visualize how much collagen is in these pieces of lung, but also specific modifications on the collagen, specific peptides derived from the collagen that may be present at higher levels in a adenocarcinoma lung piece compared to normal. So you can see here in the adenocarcinoma, this area looks more normal, and it shows up as green, detecting these green molecules. And this area is more as red, and that's part of the cancer. And the reason we did that is applying it to cancer first is what's been fascinating to me, and a field we're getting into is often solid tumors such as these are surrounded by areas of fibrosis. And it's the fibrosis that prevents the chemotherapy from getting to these tumors, especially in the case of pancreatic cancer, for example. So if we understand how to improve the fibrosis around the tumors in combination with chemotherapy, that may facilitate access of the chemotherapy to the tumors. But I'm also interested in applying this technique specifically to lung fibrosis. Now our next step is applying it to scleroderma lung to find the peptides and collagen modifications. So these are modifications of the collagen proteins that can be seen in scleroderma, but not normal lung tissues. All right, I've spent time writing an opinion piece that talks about pulmonary fibrosis called Something Old, Something New, Still Waiting for a Breakthrough. And it was a lot of fun to write this. I was given 48 hours to write it. So it was a little bit of a challenge, but it was fun. I worked with Doctors Argula and Ward. Many of you know Dr. Ward because she also sees scleroderma patients. Dr. Argula is in pulmonary and is interested in pulmonary hypertension to write a review on pulmonary hypertension in scleroderma. And I said, in addition to the science, I'm interested in sort of educational programs. And I set up a new type of journal club for students that will guide them through sort of what I'm talking to you about. How do you start with a basic discovery at the bench? How do you take it to a drug development phase? How do you take that phase to a clinical trial phase? And then how do you disseminate the information and implement the use of this drug in the community? So that was a fun journal club, and that we are now doing every year with the students. We also had a bunch of international collaborations. These are examples of collaborations published in the past year from all over the world. And I won't spend a lot of time on them, just so you know that we are also working with others, because I think we move faster at a faster pace in research if we all work together and help each other out. So the last thing I wanted to update you is our peptide, because I know there was a question last week on our peptide. So this E4 peptide that we developed years ago is a piece of collagen 18. So this is collagen 18. There are many, many, many types of collagen molecules. And this last piece that you can clip off of collagen 18 is called the endostatin. And endostatin had been studied for its anti-angiogenic properties, means it can block new blood vessel formation, which is especially important in cancer, because if you block new blood vessel formation by the tumors, you can block the spread or metastasis of tumors. And we found that a much smaller piece of this endostatin, which is right here and shown here, has anti-fibrotic properties. And so we've done a lot of work and published a lot of this over the years. And the progress we made over the past year on this peptide, and I want to go back here to the lysyl oxidase enzyme I mentioned. So in addition to it cross-linking the matrix, we looked at lysyl oxidase in the serum of mice who were given bleomycin to induce lung fibrosis, or who were given our peptide with bleomycin to reduce fibrosis. And we looked in the blood, basically, of the mice. And what we found is that when you induce lung fibrosis in the mice, the levels of this enzyme go up in the blood of the mice. And when you treat the mice with the peptide and you reduce the lung fibrosis, what we notice, levels of this enzyme, lysyl oxidase, go back down. So what that says to us is we have identified a biomarker that now can be used in patients when we get the peptide into patients to show response to therapy. Having a biomarker is what most companies dream of having when you're doing a clinical trial, because it's good to have an easy marker to follow in the blood when you know there's a good response to the treatment, and to monitor how patients are responding to the treatment. So that has been an extra step that will facilitate getting the trials going for the E4 peptide. Also, what I wanted to mention is that the peptide has been manufactured. Many of you know that the goal is to make this peptide in the leaves of plants. This is a very distant relative of the tobacco plant. This is the facility that's making it in Texas, and the plants are grown in these trays. The temperature is maintained fairly constant, so that there isn't more than a 2-degree difference between the top shelf and the lower shelf. And these are the pink grow lights, basically, for the plants. So they were able to manufacture it in this facility in Texas, in the plants. We are going to do one last phase of testing of this last batch of peptides, and then the plan is to submit for approval to the FDA sometime later this summer, with the hopes of being able to start the phase 1 clinical trial in the fall. So I know there were questions last week about a status, but this is where we are with the peptide currently. What projects do we have for 2021 that are ongoing, either submitted as manuscripts, under review, under revision, or in the works, being the data being prepared to submit as a manuscript? We have work showing that there are epigenetic changes in twins with scleroderma. So if you take twins with scleroderma where one has scleroderma and the co-twin is healthy, we found that there are changes on top of the DNA we call epigenetic changes that differentiate the patients with scleroderma from their identical twins. We have been comparing thousands and thousands of genes, which genes are turned on, which genes are turned off in the lung tissues of scleroderma patients, and trying to compare Caucasians from African-American patients, because we know that the disease is more severe in African-American patients, and we would like to know why, because once we get to the therapies, we would like to know that they're going to be effective in everyone, or are they specific for certain groups? And we just want to make sure that we understand what is the difference in the lung tissues based on ethnicity, to understand if it's going to be a one size fits all for the treatment, or if we need to personalize the treatments. We have found a very exciting link between glycolysis and fibrosis that we are pursuing at this time as well. And I'll be able to tell you a little more detail about it next year. We have found a new receptor for one of the major fibrotic growth factors in scleroderma, and we're now confirming that this receptor is functional and what signals it transmits into the cell. And we are looking at extracellular vesicles, which is kind of what they mean, these tiny, tiny pieces of cells that the cells put out, basically with content, with proteins in them that serve as messengers between cells. We're working on determining how they are different in scleroderma fibroblasts and how they communicate with the fibrosis signals to normal fibroblasts. So that's another project that's going on in the lab. So we have a lot going on in spite of the pandemic and having to slow down the research. Hopefully I'll have more updates on these for you next year. So with that, I leave you with hopefully a lot of hope that we're making a lot of progress. We're understanding a lot more about the fibrosis puzzle in scleroderma, and we're eagerly working towards a cure. And this is my team pre-pandemic. Some people graduated from their training phases and moved on to the next phase of their career, and some are still around, like Dr. Deanna right here. And this is during the pandemic, everybody working in the lab, taking precautions, thanks to the Scleroderma Foundation South Carolina chapter, who sent everybody a mask to wear in the lab. You can see them wearing the Scleroderma Foundation mask. So thank you for that. And I'll end with my slide about why research is important. Yes, it is expensive, but it's certainly better to spend money on research than to spend money on the disease all the time. And thank you for your attention, and I will stop there. Hopefully I didn't go over, and happy to handle the questions however Karen thinks is best.
Thank you so much, speakers, for being with us. And thank you so much, team, for pulling this together. We have learned a lot.
Yeah.
And we made it. We survived. I'm so happy.
Thank you. Thank you. Thank you. Thank you.
Thank you, guys. See you soon. And we will see each other on better days, vaccinated, and give each other some hugs soon.
Thank you.
Thank you.
Bye, guys.
Bye.
Thank you.